From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello and welcome to our listeners around the world. This is the JAMA Surgery Podcast, and I am your host, Dr. Amalia Cochran. Our topic today is the association between surgeon stress and major surgical complications, and I have the opportunity today to discuss this with Dr. Jake Awtry.
Thank you. It's great to be here.
And Dr. Antoine Duclos.
Thank you. Nice to meet you.
Both of whom are affiliated with the Center for Surgery and Public Health at Brigham and Women's Hospital in Boston, and they're discussing this study on behalf of the Top Surgeons Study Group. I specifically mentioned the Top Surgeons Study Group because I'm eager to learn more about this particular group. How was it developed and what is the focus?
So the Top Surgeons Study Group was established almost 5 years ago, and it consists of 45 surgeons, only attending surgeons, not fellows, not surgeons in training, who are all working in the operating room of the Lyon University Hospital in France. And the project was initiated following the receipt of a European research grant with the idea to investigate and explore if whether patient outcomes after surgery was influenced not only by preoperative risk or the complexity of surgery, but also by the performance of surgeons. And we were particularly interested in the connection between sports and healthcare, and specifically the notion that like the elite athletes, a surgeon's performance may fluctuate over time based on factors such as their physiological parameters or those related to the operating room environment. And then during an entire year, the surgeons of the cohorts accepted to wear a sensor on their ankle to collect their physical activity, their sleep, day and night. And they also accepted to wear a polar in the OR on their chest to get their stress during operation.
What was it that motivated you all to look in more detail at the potential relationship between surgeon physiological stress and patient outcomes? And more specifically, I'm curious about why you chose to focus on the first 5 minutes of the case.
So our main hypothesis was that fluctuation in surgeon stress level during surgery could potentially affect both their technical and non-technical skills, including their surgical technique and how they make decisions, or they interact with the team in the operating room. And then we didn't know whether more or less stress compared to their baseline would be associated with more or fewer complications for their patients. And a key point was that we wanted to be sure that stress level preceded patient complication rather than being induced by those complications. That's the reason why we were only focused on the first 5 minutes of the procedure of the case. And by doing so, we could investigate the influence of stress on complication rather than the reverse, which is crucial in epidemiology, actually, when analyzing the temporal relationship between the patient exposure to surgeon stress and the subsequent occurrence of adverse events.
Yeah, and I think the only thing that I would add is that I was very excited to work with Dr. Duclos on this project because this putative relationship between stress and performance is so palpable for those of us who do operate in the operating room. It's something we feel every day, but not something that we have data to back up. And so it's something I was very excited about.
The finding about the association between surgeon sympathovagal balance and major complications is inherently interesting to me, and one of the sensitivity analyses really piqued my curiosity. What thoughts do you have regarding why the association wasn't maintained for high-risk surgical specialty procedures? And this became even more fascinating to me when I noted that the high-risk specialty procedures did maintain their association with increased LF to HF ratio, so low frequency to high frequency ratio, for patients who had an extended ICU stay.
Yeah, it's a good question. And we agree. We think this relationship's really interesting and in some ways quite counterintuitive and unexpected. And the goal of these sensitivity analyses was really to test that and apply that relationship. And I agree that the p-value for that particular sensitivity analysis for high-risk surgical specialties was not significant. But at the same time, the direction and the magnitude of the adjusted odds ratio is quite similar to that of the primary analysis. And I think in part, the confidence interval is wider there because of the small sample size. And it makes it a little bit hard to make a clear contradistinction between that particular sensitivity analysis and the overall analysis of the paper. I think what's helpful is to really step back and look at the totality of the evidence of the manuscript. And regardless of which outcome we chose or which subgroup we were examining, and sometimes the relationship was statistically significant, sometimes it wasn't, but always the direction was the same towards better patient outcomes with greater surgeon stress. And oftentimes that magnitude was quite similar. And so I think that sensitivity analysis is interesting on its surface, but overall it fits into a similar trend where, again, unexpectedly increased stress seems to be associated with better outcomes in this cohort.
In the discussion of the manuscript, you all focus on beneficial versus deleterious effects of stress in surgical performance, which I know draws to some degree on research that's been done in sports performance. Do you all think that it's possible for us to delineate in the surgical world where that tipping point is so that we can effectively intervene to keep people on the right side of it and what that might look like?
Yeah, it's a really important point. I think that's what the most interesting crux of this study is. I think that there likely is that tipping point, and we elaborate a little bit in the discussion about we think that likely with our experienced surgeons in elective cases, perhaps we didn't really push them to those stressful levels to meet that tipping point. But I think all of us know experientially and theoretically, if you're stressed enough, performance suffers. And I think that probably you could define that tipping point with a very similar study design, perhaps introducing higher stress surgeries or higher complexity surgeries. But I think if that work is going to be done, and I think it should, focusing on even a more individual level might be helpful. We describe an overall association among a cohort of 38 surgeons. And I expect that there is a tipping point, but that tipping point may not be the same level for each surgeon. Some surgeons may handle stress differently. And again, analogous to this concept of the athlete and the surgeon, high-level athletes, especially endurance athletes, are quantitatively aware of things like their heart rate and their heart rate variability on a daily basis, and actually use it to inform how they may be able to perform, how they may be able to recover and train. And I think that as we look for that tipping point in the future, understanding that tipping point on an individual surgeon level and trying to draw that connection between surgeon physiology and performance, and also ultimately critical patient clinical outcomes, is really what makes this work exciting.
I'm curious, and you may have already alluded to it a little bit with that answer, but what do you all see as our next steps in examining questions that you're generating related to surgeon stress and surgical outcomes? Because clearly this is something that we're not always necessarily thinking about in the clinical space, and yet we probably should be.
I agree. And I think there's 1,000 directions you can go since this is a relatively new area of investigation. I think first and foremost is replication. We describe improvement in patient outcomes associated with increased surgeon stress, which is not something that is intuitive, a little bit unexpected. And I'd want to ensure that these results are replicable over different surgical populations and different surgeons before we saw them as something that's truly clinically actionable. But as that's done, simultaneously gaining a better understanding of what's actually influencing surgeon stress. We measured stress, but we didn't measure what was causing it. And using this data set, we're starting to look at how environmental factors or surgeon lifestyle factors can alter surgeon stress, and understanding the inputs that lead to this variation of sympathovagal balance or stress in the first 5 minutes is what makes it something that we may be able to study more clearly in the future and even use. And ultimately, all this hinges on, can we intentionally modulate stress in a way that might alter surgeon technical performance or patient outcomes? And that will need dedicated clinical study and is actually one component of the interventional phase of the top surgeons trial, and something I think Dr. Duclos can probably speak best to.
Yeah, absolutely, Jake. In the project, following the observational period, we have a cluster randomized trial, which means that in 2023, we randomized half of the surgeons to experience a specific program, and with the other half of surgeons serving as a control group. And inspired by elite sports, again, the program included 3 complementary elements for surgeons randomized to the intervention group over the course of a year. The first component was a regular session with a professional coach, not a peer. And then they had a continuous feedback on their patient outcomes using control charts and cumulative sum charts. And finally, they had the opportunity to participate in a customized improvement modules. There were 3 modules, and the first one was dedicated to their stress, and using biofeedback and relaxation and respiratory techniques, we try to help them to manage better their stress in the OR. And then there was a module of improvements related to the quality of their sleep. And the third module of improvements were more related to their physical activity and the idea of reducing their potential sedentarity. And we are currently analyzing the data of the program with the expectation to publish it over the course of 2025.
That is incredibly exciting work. I'm looking forward to seeing that. Dr. Awtry and Dr. Duclos, thank you both so much for spending time with me today.
Thank you so much for having us.
Thank you so much.
I am Amalia Cochran, the Web and Social Media Editor for JAMA Surgery, and I've been speaking with Dr. Jake Awtry and Dr. Antoine Duclos about the association between surgeon stress and major surgical complications. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.